The purpose for the next few minutes is really to share some just key highlight in terms of the lessons that we have found them useful as we are implementing. And I think it's not to recap, not to go again into details on the implementation, which I think that has been presented enough already, but to kind of share with you what we are learning and what we'll continue to learning as we implement this program in Ethiopia. And I will start by saying the very first lesson for us in Ethiopia has been on the value of the strategic partnerships, particularly with the government leadership and involvement of the government really all throughout, from the beginning, but at each step as we're implementing the program. So our relationship with the government as well as with the regional bureaus throughout the implementation of this, from the co-creation, co-implementation, is really that partnership that we work as one team. What we have learned as well is that the partnership keeps growing as you keep learning and identifying new areas. As you see below there, we have a number of partners who have come in from the academia, research institutions, NGOs, but also donors, and the bureaus as well as the Ministry of Health leading this effort. So partnerships are key. From the beginning for us, the lesson had been, MMS is not just a mere switch of the pill, but really is an opportunity to improve delivery of maternal nutrition services in the context of ANC. And in line with that vision, the way we have designed the demonstration program has really gone beyond just the introduction of the pill itself, but really addressing issues relating to how can we generate demand for services, knowing that from IFA, women were coming in late for antenatal care, but also are coming less frequently. And it will be key for us to make them come early, more frequently, so they could comply and adhere to the right or optimum level of uptake for MMS to replicate what we know from the global evidence. Also, it's an opportunity for us to learn more around issues of quality of services and how we can increase coverage, uptake. And secondarily, also, as part of this demonstration program, we work with partners who came in later, Maria Stopes International, and you've heard a bit about it, in terms of exploring market shaping approaches, particularly social marketing approaches, but also starting discussion around local production of MMS in Ethiopia. The diagram is just to show we have two broad sort of implementation approaches, the rural, which is more of the public approach, and the urban, which is more of the social marketing. When we started, we had an incomplete theory of change for flexibility. We like that because it allows us to change, but with a very simple goal. And the goal was by then, by 2024, to have introduced MMS to pregnant women in 21 warriors. These are 21 districts in Ethiopia. I'm happy to say that with the leadership of Ministry of Health, today we have doubled that. We have additional 24 districts that have introduced MMS. So we're implementing MMS now up to around 45 warriors, including the newer addition of the emergent settings warrior. As we're designing, the key thing that we had beyond simplification is also the size of the implementation program. The Ethiopia demonstration program today perhaps is the largest program in the region, and that is for the reason that we wanted to mimic as much as possible the scenarios that we'll encounter as we scale up this program sustainably nationwide. And purposely for that reason, we stick to use the existing system. We didn't want to create Alexis because it's an option. You could design a smaller demonstration program and try to perfect everything. But I think the idea for us was really to mimic scale up as much as possible and learn as much of not only the effectiveness of the MMS, but more so on the science of delivering MMS in very diverse contexts in Ethiopia. We have communities that are agrarian, we have communities that are pastoralist, and things are changing. So I think that is key. As we do that, we do appreciate the complexity of the delivery platforms, all the challenges we've had about the ANC services, and that do not actually limit us. those are not bottlenecks for us to implement the program, but these are things that we continue to learn and work with our colleagues within the Ministry of Health to see how best we could parallelly improve on those ones as well. What's so special about the demonstration program in Ethiopia is a very intense focus on social behavior change. And for that reason, because we did identify a huge bottleneck is really the demand generation. That's a make or break it for the MMS when it's taken to scale. So we have worked with the Addis Ababa University to establish a center that we call the BED Lab. It's a behavioral health insight research and design lab. And the whole purpose of this center is really to lead all the sort of innovations and the research in terms of behavior change. And the center is actually applying a model that is called Journey to Health, really trying to map out all the opportunities we have to influence behavior change from the point where we provide knowledge and information or beliefs to women and communities when they make the intent to approach the health services, when they prepare the cost at the point of service, until when they exit the point of care. So they mapped out all those opportunities where we could influence behavior, not only behavior of the women, but also the behavior of the providers. And what we are learning is very useful to allow us to sort of inform the social behavior change strategy that you have heard about earlier on. The additional thing that our SBC colleagues are helping is really in terms of innovations. So they have developed around 11 prototypes, and these were co-created with communities, and they were able to test them going forward. One of the innovations that I think they've been very helpful to enhance it is a practice that is led by the Ministry of Health, is what we call the monthly mothers pregnant conferences. These are pregnant women in communities. Every month they will come into the health post or health center, and they'll have the conferences, which is facilitated by the health extension workers, healthcare providers, but also the Women Development Army cadre, part of the cadre that supports women at community. We have found it to be very empowering for women themselves as a peer-to-peer support for them to be able to sensitize particularly pregnant mothers who are new to come in early for ANC services, but also to support each other in terms of frequent visits and adherence. We hope this will enhance the number of contacts pregnant women are having with the healthcare providers, and hopefully it will be one of the opportunities for us to move beyond the 4 ANC visits, but really aspiring to meet the recommended 8 visits or 8 contacts in that case. In addition of those prototypes that have been developed by the SPC, and you have seen this earlier on, we have sort of the SPC team has worked with women and communities. They co-created what they thought would be practical in terms of solutions or practices at community level that will help women to sort of adhere to the MMS, but also the ANC services. Among the 11 prototypes that were developed, 3 have been sort of prioritized for testing, and you have heard this from my sister Kidis when she presented earlier on today. But I think what is so special about these innovations is that they are being co-created. So they are, paying a lot of attention and focusing to the context, because context matters. The co-creation also allows us to really sort of localize the messaging, because Ethiopia has such diverse communities and they could be different. So the localization allows us really to adapt those messages, not only just in terms of language translation, but in terms of what is acceptable and what will be useful in those diverse communities. We are happy to share these onwards. The other lesson that we learn is that successful implementation of any health interventions depends on the acceptability of that intervention. And I think this is key for MMS, because adherence matters. But when we try to understand the acceptability of MMS, we kind of realize that acceptability is something that we had been understanding it, but also measuring it a bit loosely. It's always on rapid assessment, qualitative. So we wanted to be a bit more systematic to understand acceptability on all that affects acceptability at different levels, but also not just acceptability of MMS to the target beneficiaries who are women, but also acceptabilities to the providers as well. And I think MMS is not different for that. And for that reason, really, we have undertaken a bit of a systematic approach to understand this, how MMS is acceptable among women, but also the providers. And we are trying to identify some of the existing frameworks, which gives interesting sort of constructs. The one that we shared here, it's one that has 7 areas, from affective attitude, burden, and so forth. And we're trying to really understand this. Hopefully, we'll have a documentation of this to share with you very soon. So yes, the global evidence exists. But again, the key lesson that we have from Ethiopia is that equally important is the science of delivery. Yeah, MMS is implemented in the context of ANC, and it's therefore very important to work in very close collaboration with the custodians of the platform, custodians of the ANC systems. This speaks to RM and CH colleagues, pediatrician, obstetrician, and I think this has been shared with you earlier on. So this is an important lesson, and I think it needs to be done from the beginning, not actually waiting towards the end. Because eventually, if you are to change the guidelines, if you are to change the practices and translate it into what is the standard of care, then it's those colleagues who have the sort of mandate or custodian of those systems or platforms needs to be able to co-lead those important deliverables. Forward-looking, beyond evidence, we do realize that as we are gathering information and the evidence for the decision, for the country, the government to make a decision on the next steps, is equally important also to consider other key considerations. In this case, we have tried to map out some of those areas that are important for us to start paying attention. For example, in the space of policy and regulations is the whole issue of coordination decision-making, the whole establishment of the tag, and how we equip the tag to be able to look at the evidence, so to prepare the tag in advance. In terms of financing, the issues of roadmap development, where we are working with R4D colleagues, really to undertake the costing, but also to be able to explore financing approaches and financing mechanism in advance, all the aspects that we have heard about match financing. So what are the opportunities that Ethiopia has when it comes to transitioning? But also the scale-up plan, knowing that the scale-up plan is not just a switch of the pill, but also will need a careful consideration of all the other investment that needs to go in preparing the system, in capacitating the healthcare workers and so forth to be able to absorb and roll out the MMS at scale. In terms of the product, we are understanding the issues of registration vis-a-vis taxes. We are learning now, particularly through the work with MSI, as you have heard, you could register the MMS as medicine, which will be sort of lesser taxation and favorable prices, but more regulations in terms of distributions, because then it has to be regulated as an essential medicine. Or you could register it as a supplement, where the tax is a bit higher, and that will affect the pricing. So all these considerations needs to be looked upon, as well as all the other aspects in terms of delivery, which I'll not go through it, but more so to speak on one last point, which is the local production. What we have learned for local production is that we're relevant and feasible. It's essential for the scale-up plan. And this is particularly for countries that are large, like Ethiopia, perhaps Nigeria and other countries, where you have a huge number of pregnant women in country to provide that initial market for the local producers. However, what we have learned, and this is the work we did with Site and Life colleagues, and now we are furthering it out with the new effort with Deloitte. What we have learned is that the local production discussion is a bit complex because it involves very complex interplays between understanding the demand, market size, supply aspects, but also all the enabling environment, issues of taxation, issues of raw material, and so forth and so forth. But also it's important to align it with the national agendas, particularly for Ethiopia. the agenda of import substitution and localization, which the government is keen on. So we are aligning this discussion as part of that agenda so as to see the government interest and support, particularly in addressing the bottlenecks that we are learning around the enabling environment. So I think these are some of the, one last, the establishment of the tag, which is a key step, and you have heard about it. But I think what we do recognize is that tag has a very critical role, and it's important that, you know, we sort of looked into how we could strengthen the local capacity and draw very close linkages and support with the regional as well as the local tags. And I think that's it. So thank you so much.